In our last lecture on the discussion of potassium, we discussed the basic physiology of potassium, what are the major players in maintaining the potassium homeostasis, and then we discussed hypokalemia, which is the decrease in the potassium plasma concentration. Now in this lecture, we are going to go towards the other spectrum. What happens when the total body potassium or the plasma potassium increases? A condition known as hyperkalemia. As I told you that the normal plasma potassium is very strictly regulated, and the normal plasma potassium level is about 3.6 millimoles to 5.5 millimoles. So any plasma potassium concentration above 5.5 millimoles signifies hyperkalemia or is defined as hyperkalemia, an increase in the plasma potassium concentration. Now, what can be the various factors that can cause hyperkalemia or an increase in the plasma potassium concentration? Once again, with the help of a schematic, let's see what happens in a normal person and what happens in someone with hyperkalemia. As we know that about 98% of the body's potassium is intracellular and mostly in the body muscles, the muscle cells. So this is the normal representation in which a majority of the body potassium is contained intracellularly and a few potassium ions are in the extracellular compartment. Now what happens in hyperkalemia, that the extracellular potassium concentration increases to a large extent, and this can cause a lot of problems. As we all know that potassium is much needed for the membrane stability. It is a major cation, major intracellular cation that determines the resting membrane potential. So whenever there is hyperkalemia, that can lead to excessive depolarization of the membrane and the membrane becomes unstable. Just like as in hypokalemia, when there is a decreased plasma potassium concentration, there can be hyperpolarization. In the hyperkalemia, there can be an excess of the extracellular potassium, which can lead to a depolarization problem, and eventually it can also lead to muscle weakness. We are going to see the various clinical features in the coming slides, but this schematic represents what happens in hyperkalemia. Now, let's look at the various causes of hyperkalemia. Whenever we have a deranged potassium level, the number one thing is to check that whether this is a true hyperkalemia or whether it is a false reading or some artifact, preferably most likely a lab error. This condition is called pseudohyperkalemia or false hyperkalemia. What can be the various things that can cause pseudohyperkalemia? Whenever there is some excessive cellular efflux, what can be those conditions that can be causing the cellular efflux or the movement of the potassium from the intracellular compartment to the extracellular compartment? Someone with thrombocytosis or excess of the red blood cells, or thrombocytosis, excess of the platelets, erythrocytosis, excess of the RBCs, or leukocytosis. So any abnormality or excess of the blood cell lineage, whether it be platelets, white blood cells, or the red blood cells, that can lead to an excess of the cellular efflux of potassium. Similarly, in vitro hemolysis, this can be either be when you are drawing blood from some person and he or she is very tightly holding his fist, then that can lead to a cellular efflux of the potassium and can lead to a false reading. So whenever you have a patient who is otherwise stable and you're not expecting a potassium abnormality, and you find on the lab that this potassium abnormality, that patient has hyperkalemia or greater than 5.5 millimoles of potassium, then you must always counter check to see that whether this is an artifact or not, whether it can be a result of some hemolysis or some thrombocytosis, whether the person has recently been transfused blood or anything like that. So it's always good to counter check so that if on repeat reading the potassium level comes out to be normal, then you are done and you don't have to do anything else. Otherwise, you might be led in the different direction, which is unnecessary testing and unnecessary wastage of time. Similarly, there can be some red cell membrane transport problems in specifically hereditary problems, some ion channel abnormalities in RBCs, and these are very rare conditions, and you are not likely to see them in general practice. But you should be aware that, especially if this hyperkalemia is unexplained and you can't find any underlying abnormality, and it presents in very young age or in infant population, then you have to consider the hereditary defects in the RBC transport membrane. So these can be a few causes of pseudohyperkalemia. And once you have established that on rechecking that the patient does have true hyperkalemia, then we are going to proceed with looking into the various important causes. Now, just as we talked about in hypokalemia, that hypokalemia can be caused by the movement of the potassium from the extracellular compartment to the intracellular compartment. In hyperkalemia, everything opposite happens. In hyperkalemia, the potassium moves from the intracellular to the extracellular compartment. Now, what can be the various causes of that shift from the intracellular to the extracellular compartment? Just as in hypokalemia, we discussed that excessive stimulation of the sodium-potassium ATPase on the membranes that can lead to movement of the potassium in. So just mentally reverse all these conditions. Anything that blocks the sodium-potassium ATPase on the cell membrane, it can lead to hyperkalemia or excess of the potassium in the extracellular fluid compartment. Let's look at some of these causes. Acidosis. Acidosis is an excess of the hydrogen ions in the extracellular fluid or the plasma compartment. As we all know, and as we discussed in the previous lecture, that the cells have a hydrogen potassium ATPase. So whenever there is acidosis or an excess in the plasma hydrogen ion concentration, the hydrogen moves inside the cells, and to maintain electron neutrality, one potassium moves out for one hydrogen movement in. So that leads to, if there is an excess of the hydrogen ions in the plasma or the extracellular fluid compartment, then via this counter transport mechanism, hydrogen can move inside the cells, and to counteract that, potassium moves out, and when this happens in excess, this can lead to hyperkalemia. Similarly, any hyper-osmolar condition, for example, an excess of the plasma glucose or excess of the urea in patients with renal failure, hyper-osmolality draws water from inside the cells, and with water, excess of the water movement, there are some potassium ion movement as well, because potassium is the major intracellular cation. And with that, this can lead to an excess of the plasma potassium concentration or hyperkalemia. Beta-2 adrenergic antagonist. If you remember, we talked about the beta-1 adrenergic, beta-2 adrenergic agonist causing hypokalemia. So just to reverse that, any blockage of the beta-2 receptors, that can lead to hyperkalemia. Beta-2 receptors, as you know, they are the ones that can lead to movement of the potassium inside, or these are the receptors on which the asthma drugs act, like lev-albuterol or albuterol. So any antagonism of the beta-2 adrenergic agonist, that can lead to downstream antagonism of the sodium-potassium ATPase, that leads to hyperkalemia or the movement of the potassium from the intracellular to the extracellular fluid compartment. Digoxin is a drug which is used for heart failure, and digoxin and the related glycosides, that can also lead to hyperkalemia. If you remember, we talked about that in hypokalemia is a risk factor for digoxin toxicity. So the basic thing what happens is digoxin and potassium compete for a receptor on the membrane on the cells. So whenever there is an excess of the digoxin or digoxin toxicity, that can occupy excess of those receptors, and potassium has nowhere to attach. So that leads to an excess of the potassium in the extracellular or the plasma compartment, and that can eventually lead to the symptoms of hyperkalemia. Similarly, there is a condition called hyperkalemic periodic paralysis. If there is a very large number of potassium ions, that can cause a paralysis-like condition, and this can be an ascending condition with the muscle damage or the muscle paralysis ascending from downwards to upwards. It is a similar condition to hypokalemic periodic paralysis, if you remember, but in that condition, the potassium level is low. This is caused by an excessive of the depolarization of the membranes of the muscles, and that can lead to a periodic paralysis. And this is a rare condition, but you should keep it in mind that if someone is presenting with ascending paralysis, as we are going to see in the clinical features, and if you have ruled out the other conditions like GBS or other, and you can't find any reason, that you must also check the potassium levels, because that can be because of some excess of the extracellular potassium ions. Similarly, we have some amino acids like lysine, arginine, and the aminocaproic acid. These are basically the positively charged acids. So these also compete with potassium for some intracellular receptors or for some transporters, and when these are present in excess, potassium can increase in the extracellular compartment because of because the potassium is unable to bind to the transporters in the presence of these lysine and arginine and aminocaproic acid. So this is a very rare cause of hyperkalemia as well. The major ones to remember here are acidosis, hyper-osmolality, the beta antagonist, and specifically hyperglycemia. Succinylcholine is also a very important one to remember. As you know, the succinylcholine is being given during anesthesia, and it can lead to an excess of the muscle breakdown. It can lead to very high temperatures as well. So whenever there is hyperthermia because of excessive choline, excessive succinylcholine or succinylcholine related toxicity, that can lead to muscle breakdown, and it can release a large number of potassium ions into the plasma or the fluid or the blood, and these can lead to symptoms of hyperkalemia. So succinylcholine toxicity, specifically in someone who has undergone anesthesia, is a very important thing to keep in mind. Similarly, anything that can lead to cell lysis, for example, rapid tumor lysis, you have started chemotherapy of some patient and the cells have started breaking down rapidly, that can lead to an excess of the efflux of the intracellular cations and anions into the plasma, and potassium is the major intracellular cation. So that can lead to hyperkalemia along with some other issues like uric acid abnormalities. And that potassium, large efflux of potassium can damage your kidneys. It can cause acute renal failure as well. So whenever we start chemotherapy, we advise the patient or we give them a lot of fluid so that they can they can urinate out the excess of the intracellular components which are being released because of the tumor lysis or the breaking of the cells. So these are a few conditions that can cause the transcellular shift of potassium from the intracellular compartment to the extracellular compartment. Continuing this discussion. Now, what can be the various conditions that can lead to retention of the potassium or the inadequate excretion? Kidneys are the major players of potassium excretion, as we all know. So whenever there is some kidney abnormality or renal abnormality, that leads to a deficiency or a defect at the level of the tubules in secreting the potassium, that can lead to an excess of the plasma potassium concentration. Let's look at the renin-angiotensin-aldosterone axis system. We all know that aldosterone acts on the distal convoluted tubule or the cortical collecting duct at the level of the cortical collecting duct, and it leads to the retention of the sodium and water and excess secretion of the potassium. So any inhibition of this renin-angiotensin axis or any inhibition of the aldosterone leads to the retention of the potassium. So this is one of the major causes of hyperkalemia, specifically in normal population. Kidneys are the major players in potassium abnormalities. So the major causes of the potassium abnormalities are generally at the renal level. What can cause the inhibition of this axis? A large number of drugs which we give to the patient, specifically someone who has high blood pressure and has diabetic nephropathy and is taking ACE inhibitor. ACE inhibitor, you know, it inhibits the angiotensin 2 and it leads to downstream blockage of the renin and aldosterone system. Similarly, renin inhibitors like aliskiren, it can also cause this inhibition. The angiotensin receptor blockers are also a few drugs like valsartan or losartan. They can cause this inhibition. Similarly, any blockade of the mineralocorticoid receptor or the ENaC channels, for example, we have spironolactone or amiloride. These can lead to the inhibition of the renin-angiotensin axis. Most of these are the drugs which we commonly use for hypertension or some other disorders. So in these patients, we have to be very careful with the potassium level, and we have to check the potassium on a fairly regular basis to look for whether the potassium is going up or not, because hyperkalemia can very much be present with very much non-specific symptoms. You can't look out for some specific symptoms of hyperkalemia, and if it goes to excess, it can be lethal. It damages the heart. It can lead to a lethal arrhythmia, and the patient can go very quickly. A patient can die very quickly. It has a high mortality rate. So whenever someone is using these drugs, it is very important to have an eye on the plasma potassium concentration. And if the plasma potassium is going up, then you have to look for some other way or either regulating the drug or some way of getting rid of that potassium from the body. Similarly, the blockade of the ENaC channels, I just told you, with the help of a drug called amiloride, it is also one of the causes of hyperkalemia, secondary to the inhibition of the renin-angiotensin-aldosterone axis. Now, as we talked about during our physiological discussion at the level of the nephron, Whenever there is an increased distal delivery of sodium and water, that leads to an excessive absorption of sodium via the ENaC channels at the cortical collecting tubules in the principal cells. And that excessive absorption of sodium leads to an excessive secretion or excretion of potassium to maintain the electron neutrality at the level of the tubular lumen. So anything that can lead to a decreased distal delivery of sodium, be it a condition called congestive heart failure, in which the heart is unable to pump the blood forwards and there is a hypovolemic state, any volume depletion, like a person is in shock or hemorrhage or diarrhea, anything like that that leads to a decreased distal delivery because the body is conserving sodium to maintain the plasma volume, that can lead to a decrease in the potassium concentration, and it can lead to hyperkalemia at the plasma and decrease in the potassium excretion at the level of the principal cells. So this is important to keep in mind, and in these conditions, just your volume depletion most of the time gets rid of the hyperkalemia. Similarly, hyporeninemic hypoaldosteronism. This is a complex term which is basically used for any damage to the kidney and because of those damage, the juxtaglomerular cells, they are unable to secrete the renin. So any problem with the renin secretion at the level of the kidney will not activate the renin-angiotensin-aldosterone axis, and it clinically leads to the similar condition as we just talked about in the first column of the inhibition of the aldosterone or renin axis. What can be those renal conditions? Some tubulointerstitial diseases, such as someone who's having lupus or systemic lupus erythematosus, certain drugs that can damage the tubules and the interstitium, or sarcoidosis is a problem, an infection at the level of the tubules and the interstitium, someone with uncontrolled diabetes or diabetic nephropathy, in which the tubules are not working fine and they are not able to secrete the renin and lead to a hyporeninemic state. A lot of drugs can cause tubular damage. They can damage the efferent arteriole, they can damage the vessels, they can damage the Bowman's capsule. So the list is exhaustive. You basically have to understand that any damage at the level of the kidney that leads to an inadequate renin secretion, that can lead to all the problems downstream. Chronic kidney disease, or someone with very advanced age in which the kidneys are not able to function normally as in a young person, or a very rare genetic condition called pseudohyperaldosteronism type 2. Just be familiar with the term. It is a complex condition. You don't have to understand what happens in that. It is basically this column signifies any abnormality in the secretion of the renin, which can downstream lead to a decrease in the aldosterone secretion. And as we know that when aldosterone goes down, the plasma potassium goes up. So this is the basic concept here. Similarly, if there is some resistance to the mineralocorticoid, well, if the aldosterone is working fine, but at the level of the tubules, the receptors are not responding to aldosterone, this can also happen in the tubulointerstitial diseases. This can be a hereditary abnormality with few rare genetic diseases. Advanced renal insufficiency, as we talked about, or the chronic kidney disease, specifically in terms of diabetes or long-standing hypertension or polycystic kidney diseases. End-stage renal failure, this is the same concept discussed here, or acute oliguric kidney injury, someone with acute tubular necrosis, or someone who has not been taking a lot of fluids, and after a lot of exertion and his urine output is low, that can lead to acute renal failure, and clinically it can cause a similar condition as of the renal insufficiency as in the chronic kidney disease. And primary adrenal insufficiency, this is also an important thing to understand. Primary adrenal insufficiency occurs at the level of the adrenals, which lead to a decrease in the aldosterone secretion. What are the most important causes? Number one is the autoimmune. Any autoimmune destruction of the adrenal gland can lead to primary adrenal insufficiency and eventually lead to a decrease in the aldosterone secretion, and downstream cause the same effect of hyperkalemia. After autoimmune, the number one infectious cause is HIV. It has replaced tuberculosis. Previously, it used to be the tuberculous adrenal insufficiency, which was the number one infectious cause. But recent years, the incidence of tuberculosis has gone down, and the incidence of HIV or human immunodeficiency virus-related diseases has gone up, and that is the major infectious cause of primary adrenal insufficiency. Similarly, a few infiltrative conditions like sarcoidosis or some tumors, if they affect the adrenal gland, they can lead to a decrease in the aldosterone secretion. as we all know, that aldosterone is secreted by the outer cells of the adrenals. This is important to remember. The zona glomerulus is the one which secretes the aldosterone. Drug-associated abnormalities or some advanced bacterial infections, like, for example, Neisseria meningitis infection, that can lead to a widespread adrenal insufficiency along with a large number of shock-related symptoms in certain patients. And this is called adrenal hemorrhage or infarction. The Neisseria meningitis is a very important bug to remember in relation of the adrenals. So this list is a very exhaustive list of, at the level of the kidney primarily, what happens that leads to an inadequate excretion of the potassium ions out of the body and can eventually lead to hyperkalemia. All right. Now let's look at the pathogenesis of hyperkalemia. And this is essentially a revision of what we talked about in the previous slide. Let's revise our renin-angiotensin-aldosterone axis to better understand what happened in the previous slide. This is the nephron. These are the juxtaglomerular cells. They are the ones which secrete renin in response to hypovolemia or decreased sodium delivery to the macula densa, and with the help of the sympathetic stimulation, which is a counter-regulatory mechanism to counteract for the hypovolemia or the decreased stimulation of these cells. So the renin secretion leads to angiotensin 1 activation that eventually leads to the angiotensin converting enzyme converts the angiotensin 1 to the angiotensin 2, and then angiotensin 2 acts at the level of the adrenals along with a lot of other functions to secrete the aldosterone. We know that aldosterone acts at the level of the collecting duct, specifically the principal cells, and with the help of these ENaC channels, it leads to sodium absorption, and as a result, tubular lumen becomes negative, and to counteract that negativity, the potassium moves from the inside the cells to the towards the tubular compartment of the tubular lumen. This is the normal physiology which we are all aware about. So let's look at what are the various things that can disrupt this mechanism and can lead to a decreased stimulation of the aldosterone at the level of the nephron. We start off with here, direct renin inhibitor like aliskiren. These are basically various drugs which can act on the various levels. This direct renin inhibitor can lead to a deficiency of the angiotensin 1 or the decreased stimulation of the angiotensin 1. Similarly, the drugs which act at the level of the angiotensin converting enzyme, like the ACE inhibitors, which we commonly use, like captopril, the pill drugs, they are the ones which inhibit the angiotensin converting enzyme and can lead to downstream decrease of the angiotensin 2 and consequently aldosterone. Similarly, the angiotensin receptor blockers, which block the angiotensin 2 action at the level of the adrenals, and then they can lead to decreased secretion of the aldosterone. And at the level of the nephron, the aldosterone receptor blockers like the spironolactone or the apalerenone or the drospirenone, these are the basic drugs which block the aldosterone action at the level of the receptors. Similarly, there are some ENaC channel blockers like amyloride or triamterene, which we are also familiar. These are the ones that can lead to decreased stimulation of the renin-angiotensin aldosterone axis. So this is a very nice schematic to just revise what we previously talked about in this slide and what we have been talking about when we were talking about the renin-angiotensin aldosterone axis. Now let's look at what can be the clinical abnormalities in hyperkalemia. Why is hyperkalemia that much concerning for us? Potassium abnormalities can be lethal. We all know that in ancient times, potassium chloride has been used as a suicide drug among the medical staff, or if you want to kill someone, you can give him potassium chloride. So potassium abnormalities are lethal, and specifically at the level of the cardiac, it can cause some lethal arrhythmias. Whenever the potassium level goes up, specifically more than 6 millimoles, or whenever there is an abnormal ECG, even with just subnormal increase in the potassium, we have to act very quickly to stabilize the heart, because the heart abnormalities can move very quickly from a normal sinus rhythm to a lethal arrhythmias. Let's look at what can be the various manifestations of hyperkalemia at the level of our heart. It can cause sinus bradycardia, which can, or the sinus arrest, which can lead to a heart block, or it can cause the slow idioventricular arrhythmias. And at the level of the ventricles, it can lead to tachycardia, or which can eventually progress towards the ventricular fibrillation. This ventricular fibrillation, as you know, is a very dangerous condition, and it can lead to certain cardiac death very quickly. So these are the various manifestations. It can also lead to asystole. So as you can see that all of these arrhythmias are very troublesome for us, and they can progress to certain cardiac death in a matter of minutes. So it's very important whenever we have someone with abnormal ECG and or hyperkalemia, or with very high levels of potassium, and even with the normal ECG, if the potassium level is above 6, we have to stabilize the heart first, because that patient can go into an arrhythmia in just a matter of minutes. So heart is the major thing which we have to look for when we are discussing the hyperkalemia. What can be the various ECG changes in patient with hyperkalemia? The ECG changes start in a pattern. Initially, there will be peak T waves. When we were discussing hypokalemia, we saw that in hypokalemia, we have bifid T waves or very elongated T waves. In these, the T waves are peak. The peak T waves, you can understand that you won't be able to differentiate the QRS complex from the T wave, because as you can see here, this is the QRS complex and the T wave is peaked, and it has almost a similar presentation. So peak T waves is the number one thing. So whenever you have peak T waves on an ECG, the number one thing to check for is potassium. And if the potassium level is high, or if the patient is symptomatic, just start treating him while waiting for the lab, because this can very quickly move towards that small or the absence of the P waves, and can eventually move into a sine wave arrest. It can eventually lead to a lethal arrhythmias. So it is very important that whenever we have peak T waves or elongation of the QRS complex, or the small or indiscernible P waves on the ECG, and then they prolong, then they extend on towards to a sine wave arrhythmia, it is very imperative to act quickly, and so that we can protect the heart as quickly as possible. At this point of matter, the urgency oversees everything, as we are going to see in our diagnostic approach flowchart in the coming slides. So let's look at a few clinical features that the patient will present with hyperkalemia. The patient presenting with hyperkalemia have a very non-specific presentation. These symptoms may or may not be present, but if present, these symptoms, what are the major common ones? There can be an ascending paralysis, which means that the paralysis starts from the legs and moves upwards. It can involve the diaphragm as well, which can lead to respiratory problems. Ascending paralysis is present in a few diseases like GBS or Guillain-Barré syndrome. So when we have ruled out all these conditions and you can't figure out what is going on, then you have to look at the potassium level to see that whether there is some potassium abnormality that is causing this ascending paralysis. The paralysis can move upwards towards diaphragm and can interfere with the breathing, and eventually can lead to respiratory failure as well. And similarly, there can be a lot of myopathic weaknesses in the proximal muscles or the distal muscles. The patient might present with paraplegia. And these are symptoms, as you can see that these are overlapping symptoms. The patient with hypokalemic abnormalities also present with muscle weakness. So the symptoms are very vague, and with the help of the symptoms, you can't just diagnose the patient. You have to do the labs, you have to look at the various electrolyte levels, and specifically ECG. ECG is the major giveaway. If there are abnormalities on the ECG and which are concerning, then you have to act very quickly, because that can be lethal, as we just talked about in the previous slide. So what are the various important lab tests that are going to help us in diagnosing hyperkalemia? Number one, which we have to look at the electrolytes, potassium and the other electrolytes, to check for the osmolarity. And the BUN and creatinine is very important to look for the renal function, to calculate the GFR. Serum osmolality is very important. We have to look at whether the urea is high or the glucose is high. That can be causing this increase in the serum osmolality. Magnesium and calcium abnormalities can interfere and cause potassium abnormalities as well, because they are also the intracellular cations. And a complete blood count, specifically if that gives us erythrocytosis or leukocytosis, then as we have seen that they can also be a cause of hyperkalemia. So these are the basic labs which we do. The urinary pH can give us a good indication of the body's acid-base metabolism. The plasma pH can give us a good estimation of the blood whether the blood is acidotic or alkalemic, and then the other ABGs can also give us a good indication of the acid-base status. So these, as you can see, that these are the similar labs which we do in a patient with hypokalemia. So the lab work is the same, but the abnormalities are towards the extreme spectrum. In one case, there is a decrease in the potassium, and on the other side, there is an increase in the plasma potassium concentration. Osmolality and creatinine, we just talked about above, are the major ones to keep in mind, because renal failure is one of the major causes of hyperkalemia. Now, afterwards, let's talk about what is transtubular potassium gradient. This is the equation for the transtubular potassium gradient. The TTKG is an abbreviation for that, and it divides the potassium urinary potassium concentration multiplied by the serum osmolarity with the plasma potassium concentration multiplied by the urinary osmolarity. So this gives us a transtubular gradient across the tubules of the plasma and the urine, and it can help us in identifying a few renal abnormalities from one another, as we are going to see in the next upcoming flowchart. So this is the way we are going to approach hyperkalemia. This is a very extensive flowchart, and so let's go through it step by step. Hyperkalemia, as we defined, as the serum potassium concentration greater than 5.5 millimoles per liter. When we have this, the number one thing we have to check is whether it is pseudohyperkalemia or not. Whether because of making a fist of the patient's blood, this potassium level has gone up, or whether it is a result of some cellular efflux secondary to erythrocytosis, leukocytosis, or thrombocytosis. If that is the case, then we don't need to do any further action, and on rechecking if the potassium concentration is within the normal limits, then we are done for that. On the other hand, on the other extent, if the potassium concentration is greater than 6, or if there are ECG changes regardless of the potassium concentration, then that qualifies for the emergency therapy, and then that supersedes everything else. So we have to act very emergently. We're going to discuss the emergency treatment in the next slide. So if the potassium concentration is less than 6, or there are no ECG changes, and it is a true hypokalemia, then the old history, physical exam, and basic lab tests, these are your best friends in this condition. On the history, you have to look for what are the various clues, what are the various drugs intake, what is on the physical examination, is there any evidence of the transcellular shift? Number one, is there any evidence of increased potassium load? This is very rare because the body's potassium is very strictly regulated by the potassium, by the kidneys, and it is very rare for someone to be overloaded with potassium, or someone to be taking excessive potassium. This can arise in someone with renal failure. If the patient has renal failure and his kidneys are not working well, and then if he is having excess consumption of potassium-rich food like citrus fruits or bananas or tomatoes, then that can be a cause of hyperkalemia. And in those conditions, we have to counsel the patient and treat accordingly and re-evaluate the patient. If there is any evidence of the transcellular shift, like these conditions underneath, hypertonicity, for example, mannitol, or hyperglycemia, if the patient has been given succinylcholine, or aminocaproic acid, or largininolysin infusion has been given, or if there is some digoxin toxicity, if the patient is taking beta blockers, or metabolic acidosis. The metabolic acidosis, the important thing here to understand is the non-A9 gap, or the non-organic acidosis that can lead to hyperkalemia. Hyperkalemia does not occur in the A9 gap metabolic acidosis. So this is an important clinical pearl which you have to understand. And non-A9 gap, or the non-organic metabolic acidosis, can arrive in a few conditions, like you can say diarrhea can be a cause of this metabolic acidosis. And hyperkalemic periodic paralysis, as we talked about, if there is a decrease in the insulin concentration or increase in the glucose concentration, that can lead to potassium movement outside of the cells. And similarly, exercise secondary to increase in the muscle temperature and muscle breakdown can lead to transcellular shift. So if any of these conditions are present, then we treat accordingly and then reevaluate the patient after some time. But if there is no evidence of the transcellular shift and no evidence of the increased potassium load, then we have to look at the level of the kidneys, because kidneys are the major regulator. We have to evaluate whether there is any decreased urinary potassium concentration, specifically less than 40 millimoles per day. What is the tool that is going to tell us this? Are the urine electrolytes. We look for the urine potassium concentration, the urine sodium concentration. If the urine sodium concentration is less than 25 millimoles per liter, that means that the body is not excreting enough of the sodium, and there is a decreased distal potassium delivery, decreased distal sodium delivery. And this can be secondary to hypovolemia or congestive heart failure, as we saw. So we have to treat those accordingly. And most of the times, just by giving the patient IV fluids or IV sodium chloride, normosaline, this takes care of all of this. If the urine electrolytes are fine, urinary sodium is fine, then we evaluate the patient on the basis of the transtubular potassium gradient, or the TTKG. If the transtubular potassium gradient is greater than 8, then that means that the tubular flow is reduced. And this can be either in the advanced renal failure, someone who has GFR as low as 20 milliliters per minute, or there is a reduced extracellular fluid volume. So these two are the major conditions, and that can lead to reduced tubular flow and eventually lead to hyperkalemia. On the other hand, if the TTKG is less than 5, then that means that there is reduced potassium secretion at the level of the distal nephron. And this is basically a mineralocorticoid abnormality, or the abnormality of the renin-angiotensin aldosterone axis. And then we have to evaluate it further with the help of the TTKG values, specifically whether the TTKG is less than or equal to 8, or the TTKG is less than or greater than 8. Let's look at if the TTKG value is less than 8 and there is some tubular, then this majorly suggests that there is some tubular resistance, or at the level of the nephron, the tubules are not working fine. What can be certain drugs which can cause them? The aldosterone receptor blockers, or the ENaC channel blockers like the amiloride, spironolactone, triamterene, trimethoprim, and the other drugs. These can cause this tubular resistance. Or the other causes, as we just talked in the flow chart in the causes section, are the tubular interstitial diseases, or some urinary tract obstruction, or some rare genetic disease, eventually sickle cell disease, or this SLE, which can cause the tubular interstitial disease. Someone who has had a renal transplant recently, their kidneys can also be resistant to the mineralocorticoid. So these are the major causes of tubular resistance in these patients. If we are suspecting a low aldosterone in patients, then we have to look at the renin value and evaluate on the basis of that. If the renin value is low along with the aldosterone, then that is hyporeninemic hypoaldosteronism. And we talked about the various causes of this condition in our causes section. The major ones are basically any kidney abnormality which is leading to the damage of the tubules, be it the tubular interstitial diseases, or the acute glomerulonephritis, or the long-standing diabetes mellitus, or the NSAIDs and the beta blockers, or these hypoaldosteronism type 2 genetic abnormalities. These are the ones, these are very advanced diseases which can cause this hyporeninemic hypoaldosteronism. But if the renin value is high, then the major abnormality is the aldosterone production, and specifically the primary adrenal insufficiency, which is can most commonly be autoimmune or secondary to bacterial infection like Neisseria meningitis, hemorrhagic shock, or in someone who has HIV or tuberculosis. These are the ones which are the major culprits causing the primary adrenal insufficiency. There can be an isolated adrenal insufficiency in this condition. Someone who is taking heparin, or similarly ACE inhibitors or angiotensin receptor blockers, which lead to the blockage of the action of the angiotensin converting enzyme. And similarly, ketoconazole is an antifungal drug which is given to the patient, and it can lead to inhibition of this aldosterone action at the level of the kidneys, or it can lead to a decreased secretion of aldosterone and the other hormones at the level of the adrenals. This is a very good extensive flow chart and gives us a stepwise approach on how we are going to diagnose this condition. We start off with diagnosing whether it is a true hyperkalemia, then whether there are a few ECG changes or very high potassium level that leads to emergency or the urgent therapy, and we have to act very quickly regardless of the potassium concentration. And when we have stabilized the patient or relieved the urgency, then we have to look at the various causes in a stepwise manner and decrease the total body potassium concentration. All right, let's look at the treatment. Before going into the details of the treatment, I wanted to just keep in mind there are 3 steps of the potassium hyperkalemia treatment. The number one thing is specifically if there are ECG changes, we go through these 3 steps in succession. The number one thing is to stabilize. We stabilize the heart. That oversees everything, and we give certain drugs like we are going to talk about in this slide, the calcium carbonate or the calcium chloride, which act in a matter of minutes to stabilize the heart, and they have a very short half-life, and their effect goes off in very small time interval. But we have stabilized the heart, and we have protected the heart from any lethal arrhythmia. The second thing is to temporize. We try to shift the potassium from the extracellular compartment to the intracellular compartment. And this effect lasts for a matter of hours. It can last for about 10 to 12 hours and gives us a good window to decrease the total body potassium. The final step is to decrease the total body potassium either to the level of the kidneys if the kidneys are working fine, and if there is some renal failure and we are not able to decrease the total body potassium with the help of kidneys, then we have certain methods to flush off the potassium from the body via the GI tract, which we are going to discuss. So let's look at what are the stabilizing methods we have to stabilize the heart. If we have ECG changes or the potassium concentration is greater than 6, then the number one thing is to stabilize the heart. And we stabilize the heart with the help of IV calcium. Specifically, 10 ml of 10% calcium gluconate. Calcium gluconate, we give the patient IV calcium gluconate over 2 to 3 minutes with simultaneous cardiac monitoring. And this leads to stabilization of the membranes, decreases the excitability, decreases the excitation threshold of the heart, and overcomes the depolarization blockade which has been caused by hyperkalemia. So we give the patient this calcium gluconate or IV calcium, monitor the heart, and within a matter of minutes the heart stabilizes, the ECG changes start reversing. And when the heart has stabilized, then we have a good window to act, and we have taken care of the urgency. And then we can move towards the our other steps, which we are going to discuss in the next slide. One important thing to consider while treating the patient with calcium gluconate or calcium chloride for that matter is hyperkalemia, that we don't overtreat the patient and lead to an excess of the plasma calcium concentration, because that plasma calcium concentration can also cause heart abnormalities, and it can eventually lead to hyperkalemia as well via muscle damage. So one important thing to take care of this is along with the calcium gluconate, we can give the patient 100 ml of 5% dextrose in water, specifically if the patient is hypoglycemic. So this is the important thing to remember, is the number one step, as I just told about, is stabilization. Stabilize the heart with the help of IV calcium, be it calcium gluconate or calcium chloride. The next thing to take care of it is to reduce the plasma concentration with the help of the transcellular shift. Move the potassium from the extracellular compartment to the intracellular compartment. This does not decrease the total body potassium, because we need some time to decrease the total body potassium via kidneys or via GI tract. This rapid reduction in the plasma potassium concentration via transcellular shift gives us a good window to act, and can lead to sustained decrease in the plasma potassium concentration for about 10 to 12 hours, while our drugs for the decreasing the total body potassium cannot start working. What are the various methods that can lead to reduction in the plasma potassium concentration? Insulin, as we talked about, is the one that moves the potassium from the extracellular compartment to the intracellular compartment. We give the patients 10 units of IV regular insulin along with 50 ml of 50% dextrose to avoid the hypoglycemia. This is very important. Along with the insulin, what can we do? We can combine the insulin and glucose with albuterol. As we know, it is a beta-2 agonist, and it also leads to movement of the potassium from the extracellular to the fluid, extracellular to the intracellular compartment via stimulation of the hydrogen sodium potassium ATPase. This is because of the stimulation of the beta-2 receptors. What are the other options we have? Apart from insulin and albuterol, we can give the patient IV bicarb, this sodium bicarb. This is also very important, specifically in the context of someone who has metabolic acidosis. We are just killing two birds with one stone here. We are taking care of the acidosis as well, and also treating the hyperkalemias along with that. So we give 150 milliequivalents of bicarb in 1 liter of dextrose water to avoid any hyperglycemia, we can give this with simultaneously with insulin as well to have a very good and sustained and brisk response in the reduction of the plasma potassium concentration. Now that we have taken care of the two steps, we have removed the urgency by stabilizing with the help of calcium, and we have temporized the patient with the help of insulin, bicarb, or albuterol or the beta-2 agonist. Our major concern or the major motive here is to remove the potassium from the body or to decrease the total body potassium. What are the various options we have for that? We have some cation exchange resins. Specifically, the important one here is the sodium polystyrene sulfonate. Sodium polystyrene sulfonate, or it is also being referred to as K-oxalate, is a cation resin that basically traps the potassium in the GI tract and induces a diarrhea. And with the help of that diarrhea, the body gets rid of the potassium. Now, this requires multiple administration, and it happens over a period of days. With the help of one dose, you can reduce your potassium in one day. Then you have to repeat the dose over the next 2 or 3 days to get rid of the potassium. This is a very helpful method, specifically in the context of renal failure. If someone has renal failure and is not able to excrete potassium from the kidneys, then in these patients, this is the major mechanism of removal of the total body potassium. And as this takes 1 or 2 days this effect takes 1 or 2 days to kick in, we have, it's very important for us to temporize the potassium with the help of a transcellular shift during that window period, so that in that 10 to 12 hours, the patient does not go into hyperkalemia again. If the patient's kidneys are working fine, then it's very easy. Just give them some diuretics like thiazide or loop diuretics, and that can lead to a removal of the potassium by increasing the distal sodium delivery. And if the patient is of renal failure, whether it is chronic or acute, then dialysis is also very good option in those patients. But the major ones here are the cation exchange resins, are the diuretics. Dialysis is reserved for patients on which the kidneys are long-standing or end-stage renal disease patients. Dialysis is reserved for those, or in someone who has had acute renal failure and is going into oliguria or anuria, then you have to do dialysis and remove the toxins from the patient. So these are the major 3 methods of removing the potassium from the body. And we have to keep in mind that if the kidneys are not working, then GI is our major tract. And if we have working kidneys, then diuretics can take care of that. And if someone who is hypovolemic, we can just or someone with congestive heart failure, we can just give them IV normal saline. That can also help with the increase in the distal sodium flow and eventually lead to a decrease in the potassium concentration. And if we have some chronic renal failure or acute renal failure or end-stage renal disease, then along with the cation exchange resins, we can do dialysis as well to remove the potassium either acutely or over a stepwise process in case of end-stage renal disease. With that, we conclude our discussion of the potassium. In the previous lecture, we talked about hypokalemia. In this lecture, we have talked to the great extent about hyperkalemia. This also concludes our lectures on the fluid and electrolyte disturbances. I hope you have learned something new through this series of lectures, and I'll see you in another lecture. Thank you for watching sqadia.com.